starting with the title, we know topography, lecture 21, etc. This was, look please at the last page. This was the last page from last week. We started with the peritoneum, just short review, so we have to complete it. This is just for 10-12 minutes, and then we will go inside the cavity again. So this was the last topic. When we look at some maybe 2-3 diagrams, important point would be to know the position of the organs, which will be explained together with their position and relation to the posterior abdominal wall. Maybe that we could see some drawings, some diagrams, maybe that one from one book describing topographic anatomy, just for orientation in the area. We are looking into the abdominal cavity. We see the liver, we see the gallbladder with its blood supply. Then here the blue color indicates the vena porta, the portal vein, just for revision, because repetitio est mater studiorum, that means revising, it helps the students. Is the vena porta, portal vein, that collects the blood of all unpaired organs of the abdominal cavity. On its left side is the hiatus of the aorta, aortic hiatus, where we see not only the artery supplying the diaphragm, but also important truncus celiacus, celiac trunk, celiac artery, that with its 3 branches supplies the upper part of the abdominal cavity, peritoneal cavity, including stomach, spleen, pancreas, duodenum, etc. And then we see also gastric vessels. Then we see the superior mesenteric artery and vein, always the veins on the right side and there's on the left side. The superior mesenteric supplies the organs developing from the midgut, and then also a little bit more caudally, there is the inferior mesenteric, which supplies the organs which develop from the hindgut. So summarizing the facts concerning the blood supply to all the organs of the abdominal cavity, we will remember that all these organs, I mean unpaired organs, are supplied by these 3 unpaired arteries from the aorta, celiac trunk, superior inferior mesenteric arteries. Then when we look again at the posterior wall, just looking at that inferior mesenteric artery and vein, always they run together. We see also the sigmoid colon, and that's one. That's so here is the cecum and appendix. But what I mean is to revise the main things. We see that at the level L4, the 4th lumbar vertebra, the aorta divides into the right and left common iliac arteries. The iliac arteries divide into the internal iliac arteries supplying the internal organs, external supplying the lower extremity and wall, etc. The system, the complex of the arteries represents a rich network. The arteries are interconnected, and also the veins are interconnected. When we speak about the portocaval anastomosis, means that they are the anastomosis between the portal system, draining all these organs, unpaired organs, and also the veins that supply the other areas, like the parietal organs or organs which are drained into the other system of the superior or inferior vena cava. So we will speak about that several times. These are very important portocaval anastomosis. Back to the topic of the position of the organs. This is one of the diagrams. You have many diagrams in the many books and atlases. This is, I mean, very illustrative. We see some fields. For better orientation, again, this is the inferior vena cava, then the hepatic veins that receive the blood, drain the blood from the liver. Then here you see the duodenum. We remember that the small intestine, intestinum tenue, has 3 portions. One is called duodenum. That is the direct continuation. This was the stomach, as you see. So stomach and duodenum, gastroduodenal junction. Then duodenum has bulbus, the descending part, horizontal part, ascending part, and flexura. This is called duodenojejunal flexure, because the second part of small intestine is jejunum and then ileum. They are attached. I mean, these two, not the duodenum. Duodenum is firmly attached to the posterior wall as the secondary retroperitoneal organs. But these loops are intraperitoneal, but their attachment called mesenterium, this double-layered duplication of peritoneum, attaching the small intestine to the posterior wall, giving freedom for the movements which are important for the digestion. So then the attachment is called radix, root of mesentery, which is attached to the posterior wall from L2 left to L4 right side. And at the same level, L4 lies the bifurcation of aorta. This is just for a skeletal, there's a projection of the structures to the skeleton. Then the ascending colon, which is removed, and also descending colon, which is still here, they are attached to the posterior wall during the last period of development, embryonic development of the peritoneal coverings. So both mesocolons are attached to the posterior wall, forming two fields which are different. Because if we look at the position of the red pencil, we see that that line indicates or lies dividing the right field, which will be here, and left field. Important point is that not only the terminology, important point is that the right field is supplied by superior mesenteric, while the left field is supplied by the inferior mesenteric artery, important for the blood supply. And also, note please that when we leave the pencil position, following the slightly oblique line, passing from the lower part of the right kidney, crossing the duodenum, crossing also pancreas, and passing through the upper part of the left kidney. So this line indicates the position of the attachment of the transverse mesocolon. We will speak about that in the following seconds. And this transverse mesocolon divides the whole cavity into the supramesocolic and inframesocolic compartment. So that's the introduction to the important topics which will be explained right now. So when we look at the paper, so we are starting with the topography of abdomen, and we need two very important diagrams. One, because this is important for full understanding of the position of the organs. One would be the sagittal or paramedian, we could say sagittal section. So this is not possible to do direct or to start with the direct description without this drawing. This is mandatory step to do it, and this is very good for our understanding of the artistic approach to the study of anatomy in our illustrated course. Just outlines: anterior wall of the abdomen with umbilicus, posterior wall without any details, we don't need anything. Then position of the diaphragm, arch of the diaphragm, and then liver. Liver, of course, I'm leaving space. This is better for the educational pedagogical reasons. Here we have the inferior portion of the liver, then follows the stomach, gaster. Dorsally posteriorly, we are drawing the retroperitoneal organ. This is the pancreas. Wait a second. We have to start with the aorta. This is better. So dorsally posterior, there is the aorta passing through the diaphragm. Here again we have aorta, just part of the aorta, which is typical retroperitoneal organ. Now we can draw the pancreas dorsally and also duodenum caudally. Between them passes the superior mesenteric. This is good idea to draw also the position of the artery. Then drawing the wall of the pancreas using brown to color by vertical hatching the liver, the hepar. We did. Then diaphragm, definitely, muscular portion, and also the central tendon. As you remember, the central tendon is the area to which is attached superiorly cranially the heart. Done. What else? Then we need not only the stomach, we need also the transverse mesocolon. I mean that this could be good position of transverse mesocolon. Then 1, 2, 3 sigmoid colon, correct. This is just the loops of the small intestine. So transverse colon, and then small intestine. That's it. So this is the outline of our further description of the position of the organs. So starting directly with the position of the parietal peritoneum. Looking at the wall of this anterior wall, correct? Starting from the liver, we know that liver is also covered by visceral peritoneum, covering by visceral peritoneum, stopping here, then descending to the anterior inferior surface of the stomach, then the duplicature as the greater omentum majus descends freely, then runs back, surrounding the other structures. So we are here, stopping. Then we have to descend to the transverse transverse colon with the mesocolon, like that. Then returning, forming the transverse mesocolon, respecting the space in the retroperitoneum, then descending, surrounding the small intestine, intestinum tenue, with some lines. This is sufficient. Then also the sigmoid mesocolon back, descending into the floor of the peritoneal cavity, returning, covering the anterior wall, so and so, and then also the diaphragm, and finished here. So I mean that these lines, it seems to be complicated. It's not. As you remember, we have drawn it very freely. I will describe everything. And also we distinguish between the organs situated dorsally, posteriorly, and also those which are situated on the wall. Good. But that part is still not completed. So if we cover the liver inferioris, it must be covered also from here. They say the continuous process, running to the diaphragm, returning, covering the diaphragm by the parietal peritoneum, respecting again the position organs in the retroperitoneum, descending, running like that. And then what else? We are entering the greater omentum by double line, returning, definitely, returning, covering the posterior surface of the stomach, and finally joining the previous lines. So we have drawn some structures. This is the liver, hepar, correct, diaphragm, no need to mention. That area, which is not covered by peritoneum, is called area nuda, bare area, called bare area. Good, bare area, fine. And if this bare area, so then here we have, of course, aorta. All the structures should be labeled. Here we have the, this is the pancreas, correct. Then duodenum, correct. Then superior mesenteric, superior mesenteric artery supplying also the organs. Then here we have the stomach, and then that duplicature, that one, double A duplicature of peritoneum, because everything in blue is peritoneum, is called lesser omentum minus, lesser omentum, right, lesser omentum, while that one is greater omentum. And as you see, omentum, it has four layers, developmentally 4 layers, but they fuse, these internal fuses together with the second one. So this in fact disappears and developing into 2 layers again. But originally developmentally has 4. Less omentum definitely has two layers only, just attaching. The space behind this lesser omentum, using yellow, is called omental bursa omentalis, or lesser sac. So don't forget that that very important structure representing the biggest space in the upper part of the parenteral cavity is called lesser sac or bursa omentalis. Lesser sac. The English terminology describes in fact the spaces, calling this whole space as the greater sac, and that is the lesser sac. But the international terminology calls this space just the peritoneal cavity, cavitas peritonealis, and lesser sac as the only bursa omentalis as the just subspace. Good. Stomach, everything's clear. Omentum, yes. Greater omentum we have. That one is the transverse colon. Transverse colon, yes. And also, logically, that one is transverse mesocolon. And this attachment of transverse mesocolon, transverse mesocolon, and note that this transverse mesocolon is exactly pointed to the part of the duodenum, because duodenum will be also divided by the attachment of transverse mesocolon into upper and lower portion. Here we have the mesentery. This is just a mesentery attachment of small intestine, mesentery, and that one is sigmoid meso, also movable sigmoid colon. That's it. So we see all the structures found in the peritoneal cavity, including aorta, other retroperitoneal organs. So that space is called retroperitoneum. That contains descending aorta logically up to L4, where the aorta divides into right and left common ilia. So we see that this is the peritoneal cavity in full extent with all the important subunits, including lesser sac in yellow. No, so this will be this was important, and then we go ahead, just saying that the peritoneal cavity is divided into the greater sac and lesser sac, also called the omental bursa. I will use the Latin word bursa as a pouch, bursa omentalis. Yes, it lies, as you look again at the drawing, it lies behind the lesser omentum, behind the stomach, inferiorly to the liver and diaphragm. Posteriorly there's the diaphragm, inferiorly there's the transverse mesocolon. So mesocolon and transverse mesocolon. So we see that the omental bursa has its own boundaries. We will to describe it. So again, repeating the peritoneal cavity again. This is that peritoneal cavity is divided into two subunits, larger area, which is called greater sac, lesser sac, bursa omentalis. Greater sac is divided by the attachment. So I would say divided by attachment, by the attachment of transverse mesocolon. So is divided by the attachment of transverse mesocolon to the posterior, of course, to the posterior abdominal, just abbreviation wall, everyone understands. So by the attachment, I would use green to underline this, the word attachment of transverse mesocolon to the posterior abdominal wall into the supra and inframesocolic. Calling it supramesocolic compartment, yes, and inframesocolic compartment. That's it. So this is one thing. We divide this area into two parts. One is the bursa omentalis and the second greater sac. So greater sac and omental bursa omentalis. Fine. Concerning the bursa, we just say some words and we will leave it. The boundaries of bursa omentalis, I would say boundaries are just quickly, we could start with the first of all, superior. No, we start first of all anteriorly just, and boundaries, how to underline. Maybe orange would be good. Boundaries. We see the boundaries, and look, please. Here we have the anteriorly as is a stomach, gaster, stomach anteriorly, and lesser omentum. Lesser omentum is quite clear from the drawing. Posteriorly is bounded by duodenum pancreas, duodenum pancreas, covered by peritoneum, logically, pancreas, and diaphragm also, diaphragm. Superiorly, logically, only liver, hepar, inferiorly, caudally, or inferiorly, yes, hepar, inferiorly, no, transverse mesocolon, So this is seen on the diagram, mesocolon, that's it. So we know the boundaries. We fully understand that this space has some recesses. This will follow. So on the next page, we could start with just completing the omental bursa, and then we return to the supramesocolic compartment. Maybe that we can also use the letters. A would be supramesocolic, B is inframesocolic. Yes, this will be even better. So we will divide it into the superior part, inferior part, supra, inframesocolic, supra, infra. That's quite clear, sufficient, because this is more than enough at the moment. But we have to spend some time with the recessus. So we could say recessus of the lesser sac, because we still are completing lesser sac, underlined by yellow. And concerning the recessus in the lesser sac is the inferior. Inferior must be also superior, which lies behind the liver, superior, and maybe also lienal. Lienal, that's it. I mean, the details are not necessary. Some words to the lesser sac. The opening. I haven't mentioned. This is my mistake. So please return back to the first drawing and add here the obliquely passing arrow. This arrow is called epiploic foramen. Epiploic foramen. This epiploic foramen is the opening which lies behind the lesser omentum dorsally posteriorly, and the size is like an index finger or even the size of the thumb. In case if this opening will be larger, also loops of small intestine could be pushed inside, and then we call it internal hernia. So don't worry, I will put it here. So we could say that the epiploic, because now we know that there is the epiploic foramen. Yes, this is that arrow. Epiploic foramen is the entrance, the opening into the lesser sac, and the size is approximately 2 to 3 centimeters, no more. But I would say in case of larger opening, this could be developmentally based on development opening. In case of larger opening, it could be place for or seat, maybe seat of internal hernia. This is one thing. And also the omental bursa is important for one thing. Second one, as the way or approach, surgical approach to pancreas. So I would say surgical approach. Better handwriting. Approach. Surgical approach to pancreas. Yes, because pancreas is very deep, and difficult to describe directly. Fine. So I mean that this is absolutely sufficient. Before we leave the whole supramesochoric compartment, we could say we still speak about the supramesochoric compartment. Definitely, again, this is at A because we already decided that there are two compartments. We still speak about the supramesochoric compartment, and we have to say some words to the duplicatures or duplications of peritoneum, and there are some ligaments, some omenta. So we already started with the first omentum, which is the omentum minus, minor omentum, starting with the first one, lesser omentum, which is short, and we know the lesser omentum extends or passes between the stomach and the liver. Look please at one of the diagrams in the Placer Atlas. Here is the lesser omentum, you see. Again, duodenum, superior upper margin, lesser curvature of the stomach, liver, and here's greater curvature of stomach. So the space between the liver, visceral space, and the lesser curvature of the stomach is bridged by, or is covered by the, in fact, like membranous, double-layered membrane type, and it contains the vessels passing through, definitely, and also it has two ligaments, or consists of two ligaments. One is called hepatoduodenal. This is that margin. Behind that lies this the arrow. You see, this is my book, so then I am coloring it. We see the arrow indicating the epiploic foramen. And then the larger part is called gastrocolic, or gastro, so hepatogastric, or the opposite, hepatogastric, so the large one, hepatoduodenal, hepatogastric ligament. So we will describe them again, because we have lesser omentum, which consists of the hepatogastric gastric ligament, would be maybe using Roman numerals 1, and hepatoduodenal, hepatogastric and hepatoduodenal ligament, number 2, dark black, and we need horizontal section, a very simplified horizontal section. And in the horizontal section, what we see is the, look please at simplified drawing on one side, looking from below, definitely, so then the right one is on the left side. Then using the same hatching, the brownish ones, looking at the liver, right? So liver, hepar, correct, hepar, liver. Yes, covered by peritoneum, definitely. So using blue to cover the peritoneum, yes. Then on the opposite side, what we need is the stomach, correct, with the wall of the stomach. Then on that side would be also lien, spleen, lien. Also covered by peritoneum, so stomach is covered. Then drawing the hepatogastric ligament and hepatoduodenal ligament, returning back, covering the posterior wall of the stomach, and so the spleen, lien, returning and covering the dorsal organs or retroperitoneal organs. So the space here is called retroperitoneum. We are behind the peritoneum. That's why it's called retroperitoneum. The organs, just quickly, lien could be violet, stomach, the wall, definitely reddish. And finally, what we need is that the structures found in the hepatoduodenal ligament. Of course, don't worry, here must be also the aorta, and then inferior vena cava, and also pancreas must be here, because lien is is firmly attached to pancreas. So I mean that everything is here, everything is quite clear, because all these three structures are typical retroperitoneal organs. So retroperitoneum, arrow is inside, just arrow, yes, it's retroperitoneum, and that is pancreas, logically pancreas, yes, aorta with branches and inferior vena cava. I mean that this is more than clear. Fine. So of course, this is the parietal peritoneum. Fine. No, stomach, gaster, ventriculus. So then we are looking from below, from in front, and concerning the structures and spaces. First of all, coloring the space by the same color as the previous cases. So then this is the lesser sac, or bursa ommentalis. So I will just put bursa, because everyone knows this is the omental bursa. The opening labeled by the same color as in the previous case, showing the epiploid foramen. I will not label it because the arrow is more than clear, because here we have that epiploid foramen, the opening. So this is the same color, same position of the arrow. So the epiploid foramen as the narrow cleft, narrow finger size, narrow passage to bursa, which lies behind the lesser omentum. So this is the lesser omentum. Lesser omentum, which color? Maybe just dark blue. This is the lesser omentum, and we use the Roman numerals for hepatogastric, correct? So if we know that there is the hepatogastric, so it must be that one. This is number 1, yes, and that one is number 2. Maybe arrow, just arrow to number 2. So we have 2 numbers, 1 and 2. And hepatoduodenal ligament number 2 contains the following structures. Dorsally posterior is the portal vein. Then on both sides, left would be the hepatic artery, the left the common bile duct. So arrows, and we will label all the structures. So this is important for us to know that dorsally posteriorly is the portal vein, portal vein. That reddish structure is the hepatic artery, hepatic A artery, and that one is common bile duct. Common bile duct collecting or draining, transporting blood to the gallbladder, and also directly to the papilla of the duodenum. So this is the last drawing. Very important to know the position, structures, boundaries of the omental bursa, etc., etc. Done. There is also one ligament which is not bad to mention. Also one ligament, because here we said lesser omentum one structure, and we could say that another ligament is in this area is called phrenicocholic. Phrenicocholic ligament. Just sketching, if you see the diaphragm, there is a ligament in green. It distance from diaphragm, being attached to the transverse colon. This is colon, grand transverse colon in the better left colic flexure, because we know that this is on the left side, left colic flexure, correct. And to this colon is attached the ligament phrenicocholic, and on this phrenicocholic lies part of the lien of spleen. So lien, in fact, lies being supported. So I would say supports the spleen, right, or lien, both terms are frequently used. This is sufficient. Good. And then what else? So we are leaving the supramesocolic compartment, and at B, because now we are approaching to the inframesocolic compartment. This is B, and we know that inframesocolic compartment is bounded by, or a space between. This is space between between transverse mesocolon, transverse mesocolon, and no, what else? And peritoneum, pelvic peritoneum, even better, pelvic peritoneum. Yes, the inframesocolon compartment is divided, as we said, divided by, we need more place for drawing, divided by the root of mesentery. We said radix, root of mesentery. Mesentery is called also radix, is root. Radix from L2 to L4, descending from L to L4. So is divided by the root of mesentery into two fields, right and left. Right, peritoneal fields, definitely right and left peritoneal fields. Important point is that maybe that here we could complete it. No, maybe in the next page. This is sufficient. Okay, we go ahead. So now we need to draw a simple diagram in which we will see the attachment of the root of mesentery and also to the posterior wall, and also these two peritoneal fields. So next drawing, next paper, next diagram. I'm sure that we will be able to complete everything today according to our program. We are looking at the posterior wall, so just better specification, posterior wall, and it should be should have the same format. Fine, I will return back and then waiting. Okay, posterior wall, and then just sketching posterior wall. We need a slightly obliquely passing line, which is that attachment of the transverse mesocolon. Then here we would have the duodenum divided by this line. Here is the opening of the to the bulbus of duodenum. This was the stomach. You see, this was stomach here, and then here you see also the pancreas, and then we will spleen lien, and here we see the liver, etc. So these organs are above that. So this is the posterior wall. So drawing first of all the line passing through the attachment of the transverse mesocolon. So here I'm drawing this attachment. Here we have the ascending colon like that, then transverse mesocolon much narrower, then to the left side, crossing the plane, descending, forming finally the sigmoid mesocolon, opening into the rectum. So this is the sigmoid mesocolon. We see that there are two mesocolons, one is transverse, one is sigmoid. So this is quite easy to understand. Then duodenum and duodenojejunal flexure, then the attachment passing obliquely of the radix root of mesentery, and we distant from L2 to L4, so this will be L2, and here at this level, because this is attached here, this is L4, and follow please also the position of the, I'm just placing here the outline of the aorta, because aorta divides here into two arteries. So we see the aorta, and aorta divides at the level of L4. That's important bifurcation. Also, you can add also the place of the bifurcation of aorta. It lies at the level of L4. That's it. No. So here is the line. We could say that this is the attachment of transverse mesocolon, And if you look at this attachment, so simply the area or compartment situated above is called supramesocolic compartment. We already used capital letter A, and then below that is the inframesocolic compartment. So we see two compartments, and the inframesocolic compartment is different not only because of position of the organs and the different organs, but important point is that the artery that supplies all these organs is the celiac trunk. So I would say organs, simply organs in the organs A, that means organs in the supramesocolic compartment, are supplied by what? No, celiac trunk. So by celiac artery, celiac trunk. That's the different thing. But the organs in the inframesocolic compartment are supplied by mesenteric arteries. So here is the radix of mesenteries. So we would label it by green radix mesenteri. This is sufficient radix mesenteri, dividing the whole area, the inframesocolic compartment. Look, here is the radix. Yes, this is that one. And this is then divides it into two fields using a very light green. That one is one compartment. This is the right field. And using very light bluish color to show the opposite. It's like that and like that, of course. This is that area, the whole area. So then we divide it into two fields, right and left. So I mean that, do we have no nothing? So then that field is called right peritoneal field. I would just put field, which is supplied, arrow, supplied by the artery. It will be opposite, by the superior, supplied by the superior superior mesenteric artery, and inframesocolic compartment by the inferior mesenteric artery, of course, together with the veins, mesenteric artery. So summarizing the facts, we see now the posterior wall, just sketch for a simplified drawing that shows that the attachment of transverse mesocolon divides the whole space into the supramesocolic compartment, inframesocolic compartment, attachment of the radix mesenteri from L2 left to L4 right, divides the space into two fields based on the fusion of the mesocolon to the parietal peritoneum on the right side, which is the right field and supplied by the supramesenteric artery, while on the left side is the opposite. Descending colon with descending mesocolon is firmly attached to the posterior parietal peritoneum. We call it a left field and supplied by the inferior mesenteric artery. I know this is very quick revision, so we fully understand it. By the way, there is also sigmoid mesocolon. Just add one information: sigmoid mesocolon, which descends from that L2 area mesocolon, and it ends at the level of around S3. So it passes deeper S3, right there. Good. And finalizing the topic, we could say that by the process of I would say during process of or simply during attachment, because it's a procedure which starts at the beginning of 3rd month. During attachment of organs to posterior abdominal wall, appear some depressions or recesses of the peritoneum. So we we can describe the depressions of peritoneum around some organs, around the, we call them recessus peritoneales, around the, just few, around the duodenum, this is that area. Look, this is the duodenojejunal flexure here around this area, or on the right side of colon, they are the paracolic gutters, recessus paracolici, etc. Around the duodenojejunal flexure, sufficient flexure. Then around the cecum, or around or behind cecum, or along the ascending colon, etc. So all here could be the recessus peritonealis, peritoneal recesses, depressions for C, for V, and also the very specific is the intersigmoid recess, and that one is typical. So I'm just sketching. We repeat this this loop of the sigmoid, it's like that. And here what you see is the the peritoneal attachment, yes, like that. And normally the space between the loops of sigmoid colon is relatively narrow, so that means it could have around 2 centimeters. But this is the intersigmoid. But in case if the intersigmoid recess or also the other ones are larger, wider, deeper, so this is again possible. We would say possible weak area of the abdominal cavity, arrow internal hernia. So we could say that internal hernias could be found in these depressions. That's why we speak about these clinically important depressions. Done. So we completed everything, and then we go to the review of topography. So just subtitle topography of the abdomen. Just review, because this was key for the description of abdomen. Yes. No, concerning the topography, this is review definitely. So we have to start with the, of course, we have to define the boundaries. So the boundaries, yes. Boundaries. No, this is not complicated. Cranially against the thorax is the diaphragm. Easy. Diaphragm, yes. Cranially diaphragm, and inferiorly caudally. Caudally means the pelvic cavity. So we call it additus. Additus is the additus pelvis, or we could use also other term, apertura. Apertura, we have to use also this internationally used term, apertura pelvis superior, or also additus pelvis. These two terms are used. So we see the boundaries, yes. So cranially caudally. What does it mean, this apertura pelvis superior? No, bounded by promontory. We know that promontory is what? Promontory is the prominent part between L5 S1 vertebra. Then linea terminalis on the pelvic bone, linea terminalis, yes. And what else? No, symphysis, easy, symphysis. So we know the boundaries, limits of the peritoneal cavity. Palpable points, or also we could say landmarks. We call it also landmarks because some of them, some of structures are freely palpable. Landmarks. What could be palpated directly? Palpable landmarks or palpable points? No, in fact, the ribs, definitely the posterior ribs. Then xiphoid process. Below the xiphoid process is small depression where we can expect that there will be stomach, definitely. Xiphoid process. Then infrasternal angle. Yes, below sternum, infrasternal angle. What else? Infrasternal angle. Iliac crest, definitely iliac crest could be also palpable. Anterior superior iliac spine. We will need it for description of interspinous line, iliac spine. Symphysis, definitely. Symphysis. What else? Inguinal sulcus groove. Pubic symphysis, we said. So there are the points. For better orientation in the field, we also remember that there are some other points, some other palpable landmarks. For that, we need a very simple sketch, which would be, so next page, please. We are looking just at half, it was sufficient to show just half, where we have the xiphoid process, costal margin, the body, then costal margin, definitely umbilicus, linea alba, the superior anterior iliac spine, inguinal ligament, that's it. So we see also the position of the nerves that pass obliquely, laterally, and anteriorly. Then here we see the semilunar line. That means the line indicating the muscular bellies of the external oblique muscle, external abdominis, and the aponeurosis. So here we have the inguinal groove or sulcus, yes. Umbilicus, sufficient. Linea alba, yes. Then that angle is infrasternal, or just we could say xiphoid process. Good. Linea alba. Everything belongs to the freely palpable structures. The nerves run obliquely. These, what we have them, semilunar linea. We use the word linea semilunaris, semilunar line, which is between the muscular portion and aponeurosis of external oblique. The nerves here are called anterior cutaneous branches of intercostal nerves, definitely. So these are dorsal, posterior. Note please that the segmental structure or arrangement segmental arrangement of nerves, and also nerves and dermatomes. We still keep in mind dermatomes. We still keep in mind that the dermatomes are segmental, and dermatomes mean that they receive the same nerve supply or same nerves as the internal organs. So we know heads zones. So don't forget that we have head zones. We already mentioned that these head zones means that are defined by the fact that we could say simply that the internal organs have some segmental innervation, and the same segments innervate also the skin. So that's why the pain is transferred from the internal organs to the skin. So concerning perception of the skin. Good. Don't forget also lines of cleavage. Also, again, always repeating lines of cleavage, or we call it Langer's lines. What does it mean? Again, repeating, these are two important points, Z zones and Langer's lines. The Langer's lines are the lines which in fact follow the wrinkles on the skin, and they are based on the fact that the elastic and collagenous fibers are arranged in the rows of the dermis, so they run, they are related to the muscles passing in the right angle to them. So then if muscle runs vertically, so the lines run horizontally, transversally. So this was just for orientation. Lines of orientation, very important topic. Lines of orientation, orientation of the anterior. I just put on the anterior abdominal, abdominal wall. Just abbreviation. Yes. So lines of orientation, or orientation lines on the anterior wall. What we need? No, maybe also one simple drawing. Yes, this would be again through umbilicus. Then what else we need? Again, xiphoid process, costal margin, correct, wall, then anterior superior iliac spine, in inguinal ligament, ligamentum inguinale, inguinal ligament. Yes. Then the lines will be as follows. One will pass through the xiphoid process, xyphosternal. Then the next one will be subcostal, passing just on the margin of the ribs. Then next one will be transumbilical, and the next one will be interspinous, bispinous lines. Yes. Then we need also the medioclavicular line, medioclavicular. So I will add immediately medioclavicular line. This is not blue. And medioclavicular, we remember that it passes also, we already described it in the description of the orientation lines on the anterior side of the thorax. So everything is quite clear, logical. So first of all, we see these lines, and maybe that we could use also some colors. That one will be reddish. That could be also be reddish or orange, doesn't matter. And then we can divide anterior abdominal wall or the cavities into three not quite symmetric, in symmetric size, the areas. We simply call it because the wall is divided by two vertical and two transversal lines. Two vertical means on both sides they are medioclavicular, and two horizontal are subcostal and interspinous lines. We call it three areas, or better, 9 region pattern. So we could add the 9 region pattern, or later on 4 quadrants pattern. So that part which rise above, we have to mention also xyphosternal line, yes, passing through xiphoid process. Then subcostal line, I will not repeat the line. Then transumbilical line, and then that red one is the interspinal or interspinous line, or also bispinal line is also used. So we see three areas which could be colored by different colors. That could be light green, depending just on the position. Then upper one could be, we could use the blue. Okay, blue. Fine. And there are 3 areas. One is called epigastrium. That one is epigastrium. That one is called mesogastrium. Nasogastrium. And finally, that one, smallest one, is called hypo or sub-hypogastrium. So we have 3 subunits, some sub areas, and if we count the number of the regions, because there is not that much place, I preferably will use, no, some of them could be labeled directly, some of them by the letters. So starting with first one, that one is called pubic region. This is unpaired. Then that one laterally situated is called, of course, inguinal region. We remember inguinal canal. Then that area, the whole area, is called lateral region. Maybe just LR is the lateral region, correct? Then that one, this both definitely. That one is light blue, bluish, is the epigastric region. Epigastric, ER is the epigastric, important for stomach, position stomach. And laterally, here the lateral is called, not lateral, is called hypochondriac. Maybe darker, bigger dot indicates this, not lateral, we call it hypochondriac. Hypochondriac, because it's below the diaphragm, hypochondriac. So count with me. 1, 2, opposite, 3, 4, 5, 6, 7, 8, 9. Okay, finished. 9 region pattern. One thing concerning the other lines, other projections. We could say also that, just some notes, mid-clavicular or mid-clavicular or medioclavicular, both terms, clavicular line passes through mid-clavicle or midpoint of clavicle, and also the cartilage of rib 9, very important position, because on this position we will see where the midclavicular line meets the rib of number 9 lies the gallbladder. So this is one thing. Concerning the projection, the other projection, no need to put it as a special term. We can add here that xiphoid process lies at the level T10, right? This is T10. Then promontory also is projected to the interspinous line. Maybe it's not bad to put that. We are speaking about a projection, just promontory. Promontory lies on the interspinous line. Umbilicus lies at the level of the L4. This is also well known. So we know the lines, we know the positions, we know the regions. Yes. Concerning the, we need also one level, 1 point. If we have the same, just, we don't need that big drawing, that one and that one, moment, must be better. Looking at a much smaller, so here we have 4 quadrants, so we can divide the area by one median plane. This is anterior median plane, and transumbilical line. So we divide 4 quadrants: right upper, left upper, right lower, right left lower. So this is left left lower. We call it 4 quadrants. 4 quadrants. 4 quadrants pattern. So it's easy to say that we expect that we would have the cecum with appendix vermiformis, vermiform appendix in the lower right quadrant, right? Concerning the surgical approach, surgical incisions, the surgeons should go through the wall, should cut the wall of the anterior abdomen. So concerning surgical approach, we could say that because they respect also lines of cleavage, so we could say most commonly used is the used incision, definitely in the larger operation, is the line in fact following the linea alba white line. So that means from xiphoid process to pubic symphysis, right? Extremely long, but in some areas of that it's possible symphysis to cut or make incision through the wall. These are called we call them large incisions, or in the laparotomy, but there's also they use also how to say minimally invasive surgery uses now the laparoscopia, not laparotomia, but laparoscopia. That means making some punctures through the wall using the camera, using also some tools, some hooks and micro scalpels, etc. And also surgical robots use this way, this approach. So they are very small, but they are using or operating via the or using the camera and laparoscope in some small areas or short incisions, etc. I mean that this is sufficient. There is one last level. We call it vertebral level L1, capital letters L1. We call it transpyloric plane, plane or line, also transpyloric plane or line. And this transpyloric line is important to see because this line passes, and maybe that very quick section, if we have the duodenum, so this was the stomach, duodenum, descending part, horizontal ascending, yes, and duodenojejunal flexure, not need go more. Here we see the pancreas in the loop of the duodenum, then drawing the position of the kidney, right kidney with the suprarenal gland. There is the hilum of the kidney. Maybe it could be even higher. Leave it. This is not problem. This is always, then that one is like that. Fine. Hilum is that here, passing through the pancreas and crossing the lower part of the opposite kidney. So this is kidney, suprarenal gland, pancreas. We could use for pancreas yellow. No, that's it. So the line passing through the hilus of the right kidney, crossing these structures. Yes. So this transpyloric line passes through L1 vertebra, and so it passes through L1 and rib 9, rib number 9. And as you see, no, not necessary to add any comments. Here we have the gastroduodenal junction. Here is the hilum of the right kidney. Here's the lower portion of the left kidney, and here you see also the pancreas. This transpyloric plane is used for description also of some organs like stomach, liver, etc. So we will use it. No, I mean that this could be all for this moment. And so we know the orientation lines, we know the 3 zones, we know 9 regions pattern, we know 4 quadrants pattern, we know also the transpyloric line. That's it. No, and then we need half page for the projection, the title of the projection, very important topic, projection of internal organs, projection of internal organs to or on the anterior abdominal wall, just abbreviations, right? So this is the title, and if we could look at one drawing, so we need one view, we need both sides, not only half. So okay, this could be the lateral. We need half page definitely, because there were so many information. So this is subcostal, will be umbilical, interspinous. Then what we need the xiphoid process. Maybe it could be even a little bit lower position. Yes, that could be maybe a little bit changed. No, doesn't matter. So drawing the costal margins, yes, would be like that. It must be symmetry. Sorry, must be symmetry, right? So this is one thing. I already used that transpyloric line, costal margin, correct. Then this is one thing. Then here is the umbilicus, anterior superior iliac spine on both sides, like that one. And also important point would be the vertical line, umbilicus, correct, like that. Fine. No, and then subcostal line, then we need, this is the rib number 9, and here would be rib number 8. So rib 8, rib 9, then rib 9 means transpyloric. This is subcostal. We can add subcostal, then transpyloric, correct. And drawing now the organs. So here we need also, this is rib number 9, point through which passes the mid-clavicular line. This is the mid-clavicular line, what we see. And then concerning the projection of the organs, the inferior line plus the line from the rib number 9 to rib number 8 is the trigone, using yellow color, which is in fact the line that indicates the position of the Labes triangle. This is called the trigone, or we call it the anterior triangle or Labes triangle of the of the stomach, Labes triangle. So would be yellowish, we call it ventricular or Labes triangle. Labes triangle is the stomach. So for stomach, Labes triangle. So here in this area, bounded inferiorly by the ribs number 9, 9, and 8, we can palpate and see the triangle, the stomach. Above that is the area where lies where are situated two lobes of the liver. So we could say just liver, or we call it also hepatic area. We could say hepatic area, or here is the gastric area. Doesn't matter, the gastric area. Both terms could be used. Gastric area, hepatic area, that one. So we see this is quite correct. What else? Concerning the medioclavicular, mid-clavicular line, of course, it must be mentioned mid-clavicular line, and the point where meets the line with the rib number or with cartilage of number 9 is the point. I would use red. Better would be use light red. This is the point. Do we have place? Yes. So the same color. We call it. There is a fundus of gallbladder, and or we could say also fundus of gallbladder is called Marfis point. Marfis point, indicating that on the line on the point where meet the medioclavicular line and the cartilage of rib number 9 is the Marfis point, where we can expect and palpate also the gallbladder. Quite logical. Then another line is the line which interconnects this anterior superior iliac spine, that one, with the umbilicus. This line is called Monro's line of Monro's line, and this line, on this line lies the position of the appendix. So we are drawing here also the cecum. It would be like that. Here is the cecum. Yes, around 6-7 centimeters from 6-7 centimeters from the iliac spine. So that distance is 6-7 centimeters, and darker black dot shows the position of the, we call it McBarney's point, McBarney's point, and this McBarney's point indicates the attachment of appendix to the cecum, not the end. So we could say opening of appendix, of better vermiform appendix, vermiform appendix, or attachment of appendix, doesn't matter, appendix, vermiform appendix to the cecum, right? This is a regular position, and in the same position, using for instance, using green is not the best for this complicated area, but still here using green, light green, is the point which is called Lances point, and this Lances point lies in the we need also the color. Oh, which color? No, maybe yellow would be good. So on this line is this interspinous line, spinous line, interspinous line, and the interspinous line, it lies on 1/3 on interspinous line. Right on the right, usually right 1/3 on this line lies the other point, and this Lances point where we can see the tip of appendix in the pelvic position. We know that there are many positions of the appendix. One of them relatively frequent in European areas, and this is the pelvic, so 33%, for instance. So we know that is the position of the McBurney, we know Lances point. What else? No, there is also one line which passes, what color could be used? Maybe very light blue. Is the interconnection between the umbilicus and drawing the line. It's like that. Umbilicus must be, that means in that position, and the line is called axilloumbilical. It's placed here. This place here, axilloumbilical line. Axilloumbilical line, and this axilloumbilical line interconnects the tip of axilla, that's why axillo, with the umbilicus, and around, I know that this is a little long distance, but doesn't matter. In this position, in fact, in this position lies the point where is the papilla, duodenal papilla, and this point is called the Desjardins point. Thinking just about the color, maybe that one would be good, and this is called Desjardins point. And this Desjardins, 6 to 6 centimeter from the umbilicus on the line interconnecting tip of axilla with umbilicus lies the duodenal papilla. We could add, using black, very black, duodenal papilla. Yes, duodenal papilla is the papilla that receives the main pancreatic duct and common bile. So I mean that we already mentioned all the structures, all the organs, and all the points which are found on the anterior abdominal wall, like the projection on the anterior abdominal wall. What else? No, not on the anterior, but laterally. We have to know also the position of the Lien spleen. So Lien, we could say just Lien, yes. Concerning Lien, it lies on the ribs. This is Lien here, and there are ribs number 9, number 10, number 11. So there are ribs, and then Lien lies between the rib number 9 and 11. Axis passes alongside rib number 10. So this, it doesn't any extra description. Bifurcation of aorta, which lies dorsally on the level L4, is projected, projection to practically to umbilicus, or transumbilical line. Last one, stomach, also important to know. concerning stomach, relatively in fixed position lies the cardia, and cardia is projected left to to T11, sorry, and relatively stable has the position is also pyloric part, pylorus, which could be right to no L1, L2. This could be. What can we palpate? Palpable points. No. Palpable points, as you remember, any visit to general practitioner or to surgery, we know that there are some methods, definitely important methods. And first of all, this medical procedures, first one is the general view. So this is the inspection, definitely inspection. Then follows palpation, yes. Then palpation. Then we have to respect also the percussion. So using percussion, looking at the wall and trying to see the sounds from inside, and also auscultation using phonendoscope, auscultation. So there are many methods which are used for the observation, and then what would we can palpate? First of all, when we speak about a palpation, the wall must be relaxed. This is absolutely correct, because there is a tension. We know that the viscera are usually protected by the tension of the muscular wall, and in any case of any infection, any pain, so the muscular wall becomes under tension. So this is one thing. So wall, I mean abdominal wall, when we palpate it, wall should be relaxed. This is quite logical, relaxed. And what we can palpate? No, palpable areas. No, pain of the gallbladder, definitely gallbladder. Where? No gallbladder, palpable on the line on medioclavicular, midclavicular, where it meets the rib number 9. We said stomach in the Labes triangle. Also we said. Then what else? Also the appendix. Every pain of the lower right quadrant could be pain from the appendix, from the inflammatory process of the appendix. So in the right lower quadrant. So this is usually used, but surgeons can palpate in the special position of the patient. They can palpate also the deep structures. I would say also palpable deep structures. Of course, they know deep structures. The less thick wall, thinner wall of the abdomen with less fat, it's better for any examination. Deep structures, no, I would say surgeons, and what can palpate? No, in fact, also the aorta, abdominal aorta, abdominal. They can also palpate Lian spleen, especially in the case of enlarged Lian. Then they can also palpate in the superficial inguinal ring, checking the situation with the hernia, because the usually hernia can pass through the inguinal canal. So they put the finger inside and asking for coughing, asking the patient. So then they can see the reaction of the loop of intestine. So I mean that this could be all, because we already mentioned the main thing. So from point of the anatomist will be sufficient. Then we are looking at the specific situation. We are leaving the abdominal cavity, approaching to the pelvis. So we have to say that there is a part which could be lower part of of peritoneal cavity, and pelvis, and additus pelvis. That's it, because additus pelvis is terminus technicus, or superior pelvic aperture, and we could explain it using just maybe one simple sketch. Vertical half of the body, wall of the abdomen, then pelvis, bony pelvis, then the joint, hip joint, the ischial, then membrane and ischial tuberosity. Here must be also the head of femur, like that. Good. Neck, femur, correct. So this is all. It's not complicated. So pelvis would be yellowish. There is also the membrane, definitely the membranous part will be green. And here would be the lower end of the attachment of the muscles of the wall, abdominal wall. Then the line passing through this level. Then here, I know this a little bit longer, but doesn't matter. There is another line and other. So we have 4 lines now. The pelvis, greater pelvis. Between the wings of the iliac bones. That one is lesser pelvis. Yes, greater pelvis, lesser pelvis. Here we have the obturator membrane, just for better orientation. Obturator membrane, correct. And here is so then we could use different colors. Greater pelvis, just light green. That's it. We will not speak about that because there are the intestines, etc. Then this line, which is called superior aperture, we will name it, is the second area, using light blue to color. And then finally the lowest level, just like a small narrow area, is the perineum. Note please that perineum is not peritoneum. Perineum is the space between the external genitalia and rectum. Fine. So we see greater pelvis, lesser pelvis, and then note please that here we have on this line, we are approaching to the lesser, or also we call it also true pelvis, lesser or true pelvis, and this additus is called superior pelvic aperture. We have to define it. Superior pelvic aperture. No, it's not seen on the drawing. This between the like the plane between promontory. We know that promontory is L5S1, one intervertebral disc, and simply no, we could say symphysis, superior part of the symphysis, pubic symphysis. That's called superior pelvic aperture, or additus pelvis. Also, we know the word additus pelvis, Latin word, or superior pelvic aperture. And inferiorly, if we use the same color for the narrow area, so we call it perineum, which will be specific topic for one of the following lectures. So at the moment, ignore it. But that one is the inferior, inferior pelvic aperture, or exitus pelvis. So inferior pelvic aperture, which is in fact the pubis, inferior pubic rami, inferior pubic rami, then ischial tuberosities, ischial tuberosities, rosities, yes, and in fact coccyx, apex of coccyx. That's it. This is the inferior aperture. So in this period, or in this interval, we see the true pelvis, pelvis minor pelvis, and the minor pelvis. We could say, yes, lesser pelvis, greater pelvis. Lesser pelvis is divided by the muscular wall called pelvic diaphragm, by pelvic diaphragm, which is what? No, this is in fact the levator ani muscle, levator ani, into two portions. One is the pelvic cavity, true pelvic cavity, or just pelvic cavity, number one, and perineum. So we said that perineum is specific. Perineum specific one will be discussed in the lecture separately. So perineum and pelvic cavity. So pelvic cavity will follow. So on the next, in the short next review, on the next page also. We do not need any extra complicated diagrams, definitely not, because this is not necessary to draw complicated sagittal sections in both sexes, definitely not. We can see them, we can see these diagrams. Maybe that one would be sufficient for us. One sagittal section showing all the organs. This is just for orientation. We have to know the position of the organs in the pelvis. The organs are covered by peritoneum. Peritoneum forms one in male pelvis or two in female pelvis, two depressions. We call them pouches. And there is one pouch. This is between the urinary bladder on the section and the uterus. This is vesicouterine. And the second is rectouterine, and this is much deeper, Douglas's pouch, and this pouch represents in both sexes the place in which we can see the fluid from the peritoneal cavity, also the blood, etc. So this is the deepest area. Dorsal is the rectum. The space in front of rectum is called prerectal space. Behind the rectum, retrorectal, retrovesical, prevesical, and so on. So the spaces are named according to the position of the main organs. These spaces contain soft connective tissue permitting the changes in the volume. That means the movements during the defecation, during micturition, etc., etc. There is the wall. We call it urogenital diaphragm. Urogenital diaphragm. There is at the center lies the specific part of the tendon. We call it central tendon of the perineum. We will draw a diagram, and also there is the pubic symphysis, to which is that anterior part of the urogenital diaphragm firmly attached. Fine. So this is the one view concerning the representative section. One section should be completed. Yes, one section only. It doesn't matter which one, if male or female. In any case, we would remember that maybe that female would be sagittal section, and not complicated, because you have atlases, you have books, but just to have the ideas, drawing the anterior wall with all the layers, we remember them, also the compress layer, scarpas, etc. This is not necessary, absolutely necessary to draw it, the wall, and so then drawing the position of the bladder would be like that, urinary bladder, maybe a little bit higher position, like that, because we need the urogenital diaphragm. Fine, so bladder must be above that. Okay, then just improving a little bit. Bladder, yes, like that. Okay, then the urethra. Behind that lies in female pelvis the vagina. Vagina would be bounded by the vagina. This it will be definitely the pouch, but I need. Okay, and quickly drawing fundus and body and neck of uterus. That's it, fine. So increasing contrast, uterus, whole uterus, fine. Uterus, the cavity, wall of the bladder, okay, urethra, urethra, the diaphragm, and then what is important for us is the position of the rectum. This is important for us. So we are sketching just the position of the rectum, but we will pay more attention. And dorsally, there is the sacrum and coccyx. This could be all. And the anococcygeal ligament using green. So this is just sketch. I know that this is just sketch, but we don't need more. So then just coloring all the parts. This could be a shorter wall of the bladder, like that. Wall of bladder, correct. Then uterus, yes, using light red. Uterus, then wall of vagina, maybe just in black. Fornix, anterior, posterior fornix. That's it. Then using green, there is the perineal body. Then position of the rectum. Yes, just two curves, and yellowish is the sacrum, and bluish must be, as usually, the pubic symphysis. That's it. Median umbilical ligament. That's it. So I mean that this is absolutely sufficient. This is the urinary. Here we have just labeling urinary bladder. Yes, urinary bladder behind symphysis. This is symphysis. Symphysis, correct. Bladder, yes. Here we see the vagina. Moment. Here could be the line vagina. Yes. Then we call it centrum tendinum or perineal body. Perineal body as a center. Perineal body is important point which lies at the center of the perineum, supporting the structures in the perineum, in the we said place between the rectum and externa genitalia, and important in obstetrics gynecology. So I would just put obstetricians. They pay full attention to this perineal body. No, and then using red, drawing here the lines, these lines, which represent arrow. They represent the urogenital. We call it urogenital diaphragm. Right? Urogenital diaphragm. That's it. And then this is bladder, urinary bladder, correct. Uterus, correct. Uterus, and then here's the rectum. And here we see that anococcygeal ligament. This ligament is also important for obstetricians because it stabilizes or helps to stabilize the position between the rectum and posterior part, the skeleton, etc. No, and what is the most important for us to see the peritoneal covering. So here is the peritoneum, drawing peritoneum. Peritoneum covers the superior part of the bladder, and also fundus of uterus surrounding the whole uterus, anteriorly, superiorly, fundus body, as you see, and also covering the fornix, the posterior fornix of vagina, and then returning to anterior surface of the rectum. So if we see the position of peritoneum, we could see two depressions using numbers and orange color. Number 1, number 2. There are two pouches, two pouches, and they are, as we see, number 1, number 2, 1 and 2. The first one is called vesicouterine, vesicouterine, so it doesn't any extra text because this is shallower than that one. And the second one is called rectouterine, which is called also Douglas. I would use the word Douglas's pouch of Douglas's pouch, which is the deepest area in the, I would say, deepest area in the whole abdominal cavity, of course, in standing in the right position. So we know the ligaments, we know the perineal body, etc. So then, next point, spaces are many. Spaces around the organs, definitely. So the spaces are prerectal, for instance, prerectal, yes, in front of the rectum, prerectal. Then retrorectal, fine, retrorectal. Then pararectal, but para is usually named ischiorectal fossa. So I would say just pararectal, and we will speak about the ischiorectal fossa or ischioanal fossa. It's also retrovesical, etc. Retrovesical, etc. Space, retro and prevesical. So the spaces, I would just add arrow, contain soft connective tissue. So they contain soft connective tissue, and this tissue permits the movements. This is positive and important point. So we could add tissue, and they this tissue permits the movements of organs. Yes, of organs. This is positive thing, but on the other hand, this is also more complicated, important for clinics. Possible, they represent possible space or spaces of, or better, for spread of infection, or routes of infection, right? So there are 2 points. One, important mechanically for the extension or change of the position of the organs during the changes of this either rectum or uterus, or also the bladder, but also possible spaces for spread of infection, because infection is easily spread through the soft tissues. Palpable structures via, or we call it per rectum, is possible to palpate and examine some organs. In men, definitely prostate, then seminal vesicles, or vesicular glands, seminal vesicles. We can use this word, vesicles, yes, seminal vesicles, and also wall of anus. In female, also the this is elastic organ vagina anteriorly for any case, and also the posterior fornix of vagina dorsally. This is that area. Look, here is the posterior fornix. Fine. No, important. What else? We know the spaces around the rectum. We need ischiorectal fossa. There is one important muscle. When we look at we will not repeat in detail muscles, but among the muscles of the pelvis, we said that there are two groups. They form the pelvic diaphragm. I will show you diagram. Pelvic diaphragm, which is levator. We know it, and just repeating: levator ani muscle, and coccygeus, smaller coccygeus. Fine, coccygeus muscle. So levator is the most important muscle. But this is number one, pelvic diaphragm, and number two is the urogenital, more complicated, more muscles. Just to know the name at the moment: urogenital diaphragm, muscles of urogenital diaphragm, correct. And so there are two groups, muscles of pelvis: diaphragm, the pelvic, and urogenital. And among them, especially among the portions of the levator ani, there is one muscle which plays an important role in the continence and also in the defecation, etc. This is called puborectalis. Puborectalis muscle is muscle which lines in the space around the rectum, and this puborectalis must be explained in the short and following text. Look at that, please. Puborectalis. So what we need? We need one view, one simple view, looking at the muscles of the. Here is the urogenital hiatus, the opening on both sides. Then here we have we would have the rectum here. This is the rectum, and then puborectal muscle. This is that one, puborectal, surrounding as loop the rectum. Then follow the other ones, of course. Then follows the pubococcygeus, very light red, and then dorsally there is the coccygeus, etc. No need to show all of them, definitely not. Just to be informed and oriented in the area. So this is just like that. Here would be the membranous part of the of the obturator's internus, etc. No need. So we are looking from above. That muscle is that coccygeus. So this is the superior. So drawing superior view. Again, look in the atlases, the books. This is just for orientation, because we have to speak about the exact muscle. And then here, eliminating there is a pubic symphysis, definitely. So that one, the opening is called urogenital hiatus, correct, which is covered by the muscles, by the muscles of urogenital diaphragm. Here we see the rectum on the section, and muscle around the rectum is called puborectalis muscle. Puborectalis. That one, the following is this one is called pubococcygeus, just for completing information. Pubococcygeus, correct, muscle, and the last portion, the levator ani, is the ilio, the largest one, iliococcygeus, fine, muscle. All these with these dots belong 1, 2, 3, 4. There is also levator of prostate pubovaginal, could be that one. pubovaginalis. Maybe that is not bad to draw the last one or to label the last one. Levator of prostate, pubovaginalis, or levator of prostate. Levator of prostate is the same, but in male. So all these 1, 2, 3, 4, all these belong, I would say, parts of levator, of musculus levator ani. This is sufficient. So back to that muscle, this puborectalis. That one is the most important for the description. And if we see that puborectalis, I'm just sketching the pubic symphysis, correct? Then drawing the attachment of the muscle. The muscle surrounds the rectum. So drawing now the rectum, just part, rectum that forms a loop here, would be like that. Moment. It's a little bit exaggerated, not that much, but still is important to know. Speaking 6 hours, so that's why it's not that easy. Fine. And then look, here is the loop on the opposite side, and this will be all fine. Here we have the rectum, correct? Rectum, then must be better M, definitely. Then that one is pubic symphysis. Then using red, coloring the attachment and course of the muscle, forming the loop on the back side of the rectum, and then this is the opposite side. So this loop of this puborectalis, that one is the puborectalis. Yes, puborectal muscle, puborectalis, is the muscle that surrounds the rectum. The angle which passes through the axis is around 80 degrees. 80 degrees of the anorectal, we call it anorectal flexure. Anorectal flexure, flexura anorectalis, anorectal flexure, also junction, which is in normal situation around 80 degrees. What can happen? No, if this muscle contracts, so moving the rectum ventrally anteriorly, compressing rectum, it acts, I would say, function. It acts as the tertiary or the third sphincter. We call it tertiary sphincter. This muscle is also important for us just for stabilization. This is the maybe better is to say third sphincter. Even better. Third anal sphincter. Yes, it's even better. Anal sphincter. So this muscle stabilizes the position in this part of the rectum, but also acts as third sphincter. So if it contracts, compresses the rectum from behind and stops any movement inside. In defecation, it relaxes, and then the rectum is placed in the more vertical position without any compression. So this is very important function for stability of the organs in this perineal area, and also for the defecation, right? In a sphincter, I would say just note the word defecation, right? Defecation, in the defecation. That's it. In defecation. Concerning the opening, here we see the anus, right? This is anus, because anal canal has the opening anus. So if we are looking at the anus from below, anus, yes, inferior, we could say inferior view. Yes, inferior view, very simple sketch. Here we have the, it could be also vagina opening. Here we have the central tendon, which shows the perineal body, as we said, perineal body. Then follows the opening, the the anus surrounded by the sphincter of anus, external sphincter. This is like that. This must be green because this is the tendon. This is what we said. And what else? We could also draw here the anococcygeal ligament. This is coccyx. Coccyx, yes. Here's the external anal sphincter. Sphincter, yes. That one, anus, yes. Here is the perineal body, we said. The central tendon, perineal body, important for obstetricians, right? To which are attached the muscles, definitely. For instance, the superficial transverse perineal muscle, etc. We will not describe the muscles now. There is no need. And then also, moment here, I have to draw the orifice of vagina. Here is the urethra with sphincter, and here would be the pubic symphysis. So we could even add two lines ventrally, dorsally. No, and we see the two trigones. This is the orifice of vagina, orifice of vagina, urethra, female urethra, then anus, then muscles of perineum. The others are not necessary. No, and in fact, when you look at that, there are two trigones, one trigone and the second one. Any color could be used. You see, there are two trigones, and this is the anal trigone and urogenital trigone. So in the inferior view, we see the anteriorly the urogenital triangle, and then anal triangle. So two triangles. One is urogenital, correct, and one is anal. No, not bad. But what I mean is that what's important. One more thing. Here's the stabilizing ligament, which is called anococcygeal ligament. Again, stability or stabilizing factor. And if we look at the inferior side, we know the position of the anus surrounded by the sphincter. Also, one more structure should be mentioned here, which is the nerve, because we are speaking about the topography. Always is the topography. So the nerve and the artery. Maybe it's not bad to draw here the artery and nerve, which are the main nerves supplying the perineum. So this is the pudendal nerve plus the whole name is plus internal pudendal artery plus vein. We will draw, then after that we will draw one last diagram in which we will see the position of the structure. So this is the point where we see that the pudendal nerve innervating the rectum, innervating the perineum, innervating also the external genitalia. So this area is perineum, right? So don't forget that that one is the perineum. Yes, just putting name perineum. There are so many interesting structures. So the perineum will be explained separately in the lecture in the next week. Perineum, correct, perineum. And so we know also the vessels and nerves supplying perineum, and also of course they must run together with the vein, definitely. So also vein must be mentioned. Okay, and the last point for today is only one drawing, one diagram. We chose because we said that there are spaces around the look, one of the previously mentioned names were the spaces, and we said prerectal, retrorectal, pararectal, ischiorectal fossa. Yes, so it should be mentioned in last drawing, would be the ischiorectal or ischioanal rectal fossa, or space or region also. This would be next drawing. And we need what? We need coronal, so on the coronal section. So we are drawing now the coronal section, framing it, and the last drawing for today, last diagram for today. So looking at our diagram, what we need both sides. So drawing a rectum slightly curved like that, okay. Then maybe just half. One half, yes, why not? I can draw both, drawing the external sphincter, on the other side, drawing internal, it would be much better, drawing also the colossus fold, then the distal caudal part, then anus, this is what we see, this is the anus on both sides, that's it. And then looking at the attachment of the levator ani, then internal obturator, then the bone, ischial tuberosity, yes, bone yellowish, absolutely interesting. I think this is one of the last nice drawings. Muscles, yes, internal obturator, very light red, then levator ani, dark red, with the very dark part, which is that puborectalis. This is the puborectalis. Of course, the muscle must be covered by the fascia belonging to the levator ani, yes, on both sides. There is another lamina. This is the fascia belonging to the obturator internal, and it forms duplicature. I'm drawing much larger. Space is not that big, but we need it. And then this is the internal obturator, obturator internus obturator on the, again repeating, this is coronal section, muscle, obturator muscle. Then that one is the levator ani, we said, levator ani muscle. Then that canal, note please that I'm placing the arrow, is called pudendal canal, or also alcox or alcox canal. In the canal, we see, using black for the nerve, red definitely for the artery, and blue, of course, for the vein. So the canal, the pudendal canal, contains pudendal nerve, pudendal nerve, yes, and internal pudendal artery plus vein. Fine. The ischiorectal fossa is indicated by rows of the dots. So that space, using just the dots, is the ischiorectal fossa, ischioanal fossa, because we are also in the lower part. Ischiorectal, because sometimes this pointed just to that inferior portion, that's why they call it usually inferior, ischioanal. The fossa contains soft tissue, soft connective tissue, definitely, because it permits the movements of the rectum. Here we see the rectum on the section. One will be completely surface. That means that I'm drawing the horizontal lines showing the horizontal musculature on the surface, and then inferiorly there is the external sphincter. On the opposite side, on the section, we see also the triangle fold here, the wall with the internal sphincter, and also external sphincter, which forms three portions, and internally, don't forget to place the submucosal plexuses, which are called hemorrhoidal plexuses. So we see the two halves. One is the surface, one shows the wall. If we are at the level of this fold, We call, because this is a relatively constant. This is the valve, sometimes tertial valve. We call it Kohlrausch, or valve of Kohlrausch valve, and the valve lies at the level of around approximately 6 to 7 centimeters from the anal canal. So we see the anal canal. That one is the external anal sphincter, external anal sphincter. Yes, the same here. So on the opposite side, we see the brownish thick line is the internal anal sphincter, and that one, 3 portions represented by this. This is just a superior external view. This is the external, again repeating, external anal sphincter with three parts, 3 portions. Subcutaneous, superficial, deep. Not necessary to draw it now or to put anything now. Again, on the section we see very important hemorrhoidal venous plexus. Hemorrhoidal venous plexus, important for clinics. In the next minutes we will explain it. That's it. So we see the internal, that one is called ampulla also. This part is called ampulla, and that one is called anal canal. Why not? Anal canal. The length is around 12 centimeters of the whole. But back to the muscle, that one is levator ani, and that one is the place, yes, this is the puborectal, puborectalis muscle. This is that one which surrounds as a loop the rectum, acting as a tertiary sphincter. No, and then why we mentioned 7 centimeters? This is easy because peritoneum covers the wall of the rectum up to the level of that Kohlrausch's valve. So here you see that peritoneum covers and lines the cavity. Here we are in the abdominal peritoneal cavity. Here we are in the subperitoneal space. Back to the vessels. Yes, the veins leave definitely the Alcock's canal, and together with the arteries of the same name. Here is the internal pudendal artery supplying the wall, supplying also the rectum, joining with the others, passing through or around the muscles, forming the arterial plexus on the wall, being attached or interconnected with the middle rectal artery. Here would be the internal iliac artery that passes here as the, and forming also or sending the internal pudendal artery. And note please that there are 2 arteries, inferior rectal, middle rectal, right? But also with interconnections. But there is also 1 artery which comes from above, coming from the mesenteric artery, which is accompanied by the vein of the same name. So this will be the bluish, must be bluish, the superior mesenteric. So the artery is accompanied by the veins. Definitely they form the same plexus as you see with those which come from the or return back to the mesenteric. Plexuses are important, are of high importance. So just the finalizing the names. Here would be the position of the internal. It's in the more closer position, but doesn't matter. Internal iliac artery plus vein. This one moment we need. Yes, we need I would just add the vessels of the rectum, yes, and they are arteries and veins. Arteries labeled by numerals would be artery superior number 1, middle number 2, and inferior number 3. This is that lower one, number 3, number 2, number 1. Arteries and veins, both of them, number 1, number 2, number 3. Number 1 are this is the superior rectal, of course, artery or vein, both artery or vein, definitely. And this superior rectal artery plus vein comes from the inferior mesenteric artery and vein. The same is with the veins. This is the same. And number 2 has the middle rectal, and middle rectal receives the blood from the internal iliac. And the last one is inferior rectal, which comes from the internal pudendal artery. Pudendal artery is the same. This is the branch from the internal iliac. So note, please, that there are two systems now using different colors. Inferior may be, first of all, red. Inferior mesenteric is one area. These are mesenterial arteries. And the second one, using orange, come from the pudendal system or internal iliac. This is another system. And the same will be the veins, because veins will have the same names. So that one is the inferior mesenteric, will return as the superior rectal, veins same, but of course the course is the same. Superior runs up to the mesenteric, to the inferior mesenteric, and inferior mesenteric opens, as we remember, to the portal vein. So this is portal system. The remaining veins, as the middle and inferior, both of them, drain into the iliac. An internal iliac vein opens into the inferior vena cava. So that means, I will repeat, cava. So again, we speak about the portocaval anastomosis, yes, because this is the connection between portal vein, portal vein, and the systemic veins. Yes, systemic, that means caval system. And as we said, describing the lower portion of esophagus, or describing the veins around the umbilicus, when we mentioned that the paraumbilical veins belonging to the portal vein, and also the surrounding veins, the thoracoepigastric, inferior epigastric, superficial epigastric, and the others, forming the tributaries opening into the inferior vena cava. So the same, that and repeating, in case of reduced flow of blood through the liver, or even case of blockage of flow of blood flow through the liver, the liver. We know why, because there are changes in the, we call it cirrhotic liver. So all the collaterals, I would say collaterals substitute the mainstream, the main flow of blood, and then it leads to the I would say, because we have mentioned these hemorrhoidal plexuses, they become larger because of the interconnections. They may cause the bleeding, so bleeding in the rectum. That's why I'm just completing main flow, my stream, everything you can put. So collaterals substitute the main flow, and then the hemorrhoidal plexuses become larger, but they are thin, or instead become larger, we could say. Hemorrhoidal plexuses arrow bleeding, submucosal bleeding. Why to say so many words, because this is sufficient. So bleeding. So this is typical phenomenon of the cirrhotic liver, which leads to the substitution of the parallel running collateral systems, and that's why the portocaval anastomoses are so important for the plexus, because these anastomoses may cause the bleeding from the hemorrhoidal plexuses. Fine. So I mean that we did everything. So it was what was planned in our syllabus. So we don't have any rest which should be sent. In the next week we will start with the last point. We will speak about the review of the topography of the epigastric area. We didn't pay that much attention to the spaces below the diaphragm, and also maybe that if we will have a little bit more time, I'm sure that it will not be sufficient for whole lecture. So we'll add also some information about the organs. So everything's done. Thank you for attention, and see you and hear you again in the next week. Thank you, and again, leaving. Thank you. Bye bye. No.